in, so I have a year and a half left, and that's pretty much what I'm doing.
Nailed it. All right, so this is going to be super casual. I think we'll focus on part 3. I know it's obviously part 1 and part 2 already came out. But maybe we start part 3, see how long that takes. Then if we have motivation, we can go to part 1 and part 2. If y'all are interested, it does not matter to me. And I can briefly highlight, if anyone hasn't read part 1 and part 2, I just re-skimmed over it. It was, just admitting more people. So part 1 was kind of like laying the foundation for the series. And they briefly touched on like the Choosing Wisely campaigns, and then the Lancet series, the Right Care, which I haven't read. And then they kind of listed out the differences between overdiagnosis, overdetection, overtreatment. And then part 2 of this series, they looked at ineffective, inefficient, and misaligned care, and kind of dove into that. And then the part 3, which we'll mainly discuss, is diving into like the 4 domains of what's kind of driving this overuse. So I was thinking we go down each domain, chat about it. Once we are done with it, we'll move to the next domain. And then I think it would be cool if we talk about the table as well, in the middle. Yeah. And then if we have time, we can go back to overuse part 1 and part 2. So let's start with the 4 domains. So there's culture of healthcare consumption, patient factors and experiences, clinician factors, and then practice environment. So Geronimo, do you want to dive into your initial thoughts of domain 1, the culture of healthcare consumption, anything that stood out, and then maybe we kind of open it up to anyone else?
Yeah, and disclaimer, I know I'm in Cairo school, but we're just going to use the word PT because that's what they talk about in their PTs here. But obviously this goes for any MSK. But I think the main one that obviously we all know that first paragraph where they talk about misleading marketing and poor online information. We all know just how much misinformation is out there right now with everything. But to get to the PT realm, I think, and it's definitely a nuanced topic, but something like the get PT first has been able to backfire a little bit, just because I understand that the positives of getting PT over going to see your medical doctor, but something about get PT on maybe things that don't need treatment has also become a little bit of a problem, which they talk about here, where they say the physical therapy profession is not immune. Some have raised concerns that marketing initiatives could lead to unnecessary physical therapy for conditions such as back pain. So I don't know what you guys kind of think about that. That's where my head went directly when they said that. I don't know if anybody else has thoughts on something like the initiative of Get PT First or any of those initiatives.
I mean, I think you've brought up a good point, but and this is something. So I'm a PT student. I'm a second-year PT student in Boston, but I've also worked as an athletic trainer. I work as a strength coach, but there's some pretty muddy waters on like what is a physical therapist. And I think that point also speaks to the culture of healthcare consumption, in that it is consumption. Like, people like to consume healthcare at very high volumes, and especially with something like low back pain. Is that something that should be treated with physical therapy? Depending on the case, for sure. But also, I've seen through clinicals and through observing and working with different clinicians, there is also the standpoint from the PT, you need to treat to keep your job. So sometimes people end up in front of you that maybe don't belong in front of you, but your job is to treat them. And that's something that I think it's kind of both ends. You're not doing something wrong for them, but it doesn't help to unmuddy the waters of healthcare. And that's something that I think I overall took out of this, and that there's not a great triaging model for people to understand where they should fit into the healthcare system and where they belong in terms of, do I need a physical therapist? Do I need my PCP? Do I need surgery? Do I need an athletic trainer? Do I just need to train? What does exercise mean? And so it brings up a lot of those questions, I think.
Yeah, and I think adding on to that, I think it's important to for all of us to kind of be humble and not try to treat somebody that might benefit from other types of treatment. So I think one of the problems is that since we are doctors and we are looked at as doctors and somebody's coming in to get treated, even things, and we'll talk about it later when we get to the clinician part, but the moment that you give a treatment, no matter how good your narrative is, you are a doctor giving somebody something. Even so, if you say the prognosis is good, this is probably going to get a lot better if we don't do anything, and then you give a treatment, it is not, congruent with the message that you just gave, if that kind of makes sense.
Does anyone have any other thoughts about domain one, just the culture of healthcare consumption? I know it talked about it like sensationalizing inaccurate info through social media and marketing and internet. Do you all feel like it's even possible to counteract inaccurate information through media, or is it just we're speaking to our own bubble or echo chamber, and then the sensationalizing is going to their own chamber, and like no one's really kind of cross-pollinating?
Hi, Taylor. First off,
What's up, you guys?
yeah, I think Chris, you bring up a good point. Alex, great points as well. It's definitely a very a balancing act of advocating for the profession while still putting out messages that might be helpful on social media. But that's obviously a topic that's near and dear to our hearts, because as keyboard warriors trying to combat some of these big social media accounts putting out, not helpful information, to put it lightly, isn't super effective. So I don't know how much of that we can actually change, but we do obviously believe that, if we can spread the message to as many, soon to be new clinicians, students, and help them have that level of, epistemic responsibility and really think about the messages they're putting out, then I do think that over time we can see a trend in the right direction. But I don't know, that's probably pretty naive even to hope for and think, but I feel like that's something that we actually potentially have control over doing, is just trying to help spread that message to be more thoughtful with the messages we're putting out.
I wonder how much of it too that Alex sort of touched on is almost societal. Like, it's not just healthcare that we like to consume. We like to consume everything. So I think it's almost like it's a continuum, and healthcare is just one of those other things that, just like if we need something, we can hop on Amazon and get it right now, and it can be here tomorrow. I know that's a small thing, but I just think that the consumerism side of just everything in our country doesn't necessarily help this particular case.
Yeah, and Chris,
even is like, oops, sorry.
Go ahead.
No, I was just gonna say, like, on this same point, it's people want a single solution because that's what they're delivered through every soundbite of information that they can get on social media and on their television from other people. They can get this single solution. It's a medication, it's one intervention, it's any of those things, and that perpetuates this like challenge that we face. And I don't want to go. I have more thoughts on this, but I think they fall under the other categories, so I'm going to stop talking.
Yeah, I like the fact that Chris mentioned echo chambers in his question, right? Like, are we just in our own echo chamber talking to each other? But I think it's helpful to remember we all started somewhere, and we didn't just start where we're at right now. So whether we're talking to other clinicians with the appreciation that, hey, they might end up, even somewhere better than where we are now, or talking to patients, realizing, hey, if my beliefs can change, it's possible that their beliefs can change too. And then, of course, we've all had those patients where it is possible, and we've also had the patients where they don't change. But I think just recognizing that it's possible and that we didn't start where we're at can be really helpful too, to have that perspective.
I think Eric Mayer always says this, and I'm sure he got it from somewhere, but it's the problem with low back pain right now is that people think it's a medical condition when it's probably not. And being able to change that in itself is a tall task. Do you guys find that anybody in your either your local organizations or even national are pushing kind of that messaging? Just because I saw it like today, like the Lift More trial was like on the news or whatever, like something like that is awesome. So it's possible, right? Like these things are possible to get out on the news. So do you find like your local and national organizations are pushing some of these messages or anything like that? Or do you think they should? Do you like, for as much as they advocate for things like not cutting reimbursements, do you think they should also be advocating for things like being able to push some of this information out there?
So my thoughts on kind of the part about the trustworthy sites kind of goes along with what you're saying, Geronimo. I think that people generally, when they do search online, if they have, some low back pain, they just type in low back pain on Google, how to get rid of it. The sites that come up are often ones that are like Medline, Healthline, those really large sites that people tend to trust. But then you look at who's writing them, and they're usually just, bloggers, personal trainers. And so I think the problem is that you give those people the platform that reaches out to a large population. And people view those articles as trustworthy because they come off of sites that are very popular. So I don't know how to combat that, but I think that's a big problem because a lot of people just go for the first link when they search. That's like 90% of people or 90% of clicks go to that first link on the search results. And usually that's, the high authority sites. So I don't know how to combat that, but I think that's a big problem.
Have any of you guys had conversations with patients? I mean, I'm sure you have in clinic about stuff that they've seen on Google or had patients bring up, well, hey, like what you're telling me is different than what I Googled. Yeah, because I've definitely put that in people's homework before, like stop Googling is like a point of their homework. But I do think that's like an opportunity for conversation, right? Because I think I see that as a positive sign that this person is invested in learning more about their condition and they have some level of self-efficacy for educating themselves, which I just listened to the Chad Cook podcast with Zach the other day, which was awesome if you guys haven't listened to it. And he was just reiterating how hard it is to change someone's self-efficacy. And so if you're like, oh, this person already has a habit of seeking information, like let's try and turn that into a positive opportunity instead of like oh my gosh, Healthline again, because I mean, we're going to all burn out so fast if we just get frustrated by stuff like that.
I think
nope, go.
I think a cool part about this stuff is, this paper and all of these papers, is that not only are they pointing out the drivers or the problems, but they're also trying to give solutions. I think a lot we get caught up in being able to like nitpick things and pick apart, and we can pick apart absolutely anything if we really try hard enough. But I think the important part that they mentioned here is that they actually give, feasible approaches to improvement, which is why I kind of asked, like, what do you guys think that we can do about this? Especially if right now we're talking about like social media consumption, like, is there a way for us to get involved in our local or national organizations and kind of change that stuff? Just because I feel like those big organizations might have a little more power to get out in the media than maybe an individual by themselves. I don't know if you guys have tried to do something like this, or have you seen the barriers, or does anybody have any recommendations on some stuff like this? Like how you would change, like Logan said, like something like Medline or anything like that. Like, anybody thought about some of that stuff?
I mean, I haven't thought about that specifically, but I work as a graduate assistant for the first years in my program, and this just made me think about this because it was like the bane of my existence this week. They're giving a capstone presentation on physical therapy management of cervical radiculopathy and degenerative joint disease. They gave me a 30-minute presentation, 7 students, put a lot of work into this, and the outcome that they determined, which is the best management for cervical radiculopathy, was that you should recommend opioids, surgery, and that physical therapy is ineffective. And if you have symptoms for more than 6 weeks, you should have surgery. And I stopped them and I was like, we're not even going to talk about your presentation. We got to zoom out for a second. And this is what they found in trying to find information. These are PT students. And it was like, I mean, I think it goes back to Taylor, what you were talking about. One half of it is what our patients are Googling. The other half of it is the fact that students are having a hard time finding that information on the internet, and they're using appropriate resources. And they came to the table thinking that this was it. This was what they were going to present to their class. And I was like, we gotta back up. And I felt, half of it felt bad, but it was such a teachable moment, because it was like, well, let's have this conversation. Do you want to do that? You're a PT student. Do you feel good about this recommendation? They're like, no. It's like, all right, let's regroup. And it's shocking.
Mm-hmm.
I know that doesn't fix the problem, but it's more than just a patient problem.
Yeah, and I think too that highlights why it's so important for us to have kind of those big picture systems of thinking about things, right? Is I don't have any problem with someone coming to the table and saying PT is ineffective for this condition. We shouldn't treat, like frozen shoulder, right? Like, you're a dumbass dinosaur if you're seeing somebody 3 times a week for 6 months for a frozen shoulder. That's just dumb. But if you there isn't a huge harm in doing that compared to, I think of a patient, a 30-year-old that is the surgeon's pushing a cervical disc replacement, and his radicular symptoms are gone in 2 weeks. The possible harms are way bigger from opioids and surgery, right? And that's not to say we shouldn't hold each other accountable for overuse of PT, like this article was talking about. But yeah, we need to be able to talk about those same concepts that colleagues in other disciplines, like MDs, DOs, are going to talk about things in terms of harms, especially surgeons. I think that surgeons want good outcomes, right? And that's a really salient thing to address if you're having an interdisciplinary conversation too.
How does this conversation that we're having, especially going back to the Medline and a lot of that available information that isn't necessarily promoting or putting out there what we would want our patients to find, how much, because I think the story I just told really highlights the area where students are having a hard time with reconciling some of that too. Do you feel like the push for evidence-based practice negatively influences how new grads or young clinicians come out and view how to make decisions, because they feel like at least for me, we've been so taught evidence-based medicine, you need to use research to support all of your decisions. And there is research that talks about the influence of opioids on these conditions as a positive.
Right. And I think that comes, to be perfectly blunt, I think a lot of students aren't invested. A lot of people hate group projects and just want to check it off the list. And yeah, if I can find research to support anything, right? And I think it's not just, you have a study to back this up. It's, okay, where does that fit into the body of evidence, right? I don't need to, if I'm going to make a recommendation, right? Yeah, Zach's talking about has to do with appraising evidence. That's totally a huge part of that, right? It's not just there's a study. Is it good quality? But then also, where does this fit with everything else that we know, right? Hello, opioid epidemic. What would right? What rock are you living under if you think that recommending opioids is a good idea? Hello, shouldn't that at least give you pause and that's really weird that we found a study concluding that. Let's dig in a little more. But you got to have a sense of ownership to do that. And also, I will say I have been definitely guilty, lest anyone think I'm on a moral high ground about this. I've definitely been guilty of being fuck this group project and not putting in work on it if I don't believe in it. And letting classmates do dumb stuff like that.
We had, and no doubt, I think Zoom University has caused that to be even greater elevated. But it was just shocking. They were unanimously, 7 of them were yep, this is what we found. And I was like, you want to hang your hat on that? That's what you want to tell me, that you're not useful in the management of this condition? Okay.
I want to circle in here for a second. We're discussing whether or not students and clinicians can figure out what the hell they're supposed to be doing, right? And yet this mentions healthcare literacy from the patient perspective. If we, as students and healthcare practitioners, don't know what the fuck we're supposed to be doing, how are they going to figure out where they're supposed to be and what they're supposed to do? Right? So how are they ever going to get there when we can't even get there? So it's a real big question, because if they're not in front of us for us to educate, yet we're telling them, don't come in because you don't need this, where do they fall? How do they get there, right? So I think we have to be involved in some way, shape, or form to help with these conversations. But again, is that a cost driver, right? Is there efficacy there to show that we're able to change behaviors and change thought processes in and of itself? Yet their literacy isn't even there. Ours isn't even there. How do we get there is really a question, and I'm not sure that we have great answers.
Mm-hmm. Yeah. And some people then will also, to that point, Paul, will push back and be like, well, okay, like if you say you see the person once and you educate them, they will make the point that maybe you should have an extended plan of care for, 2 to 6 more visits to like make sure they don't go somewhere else, which I think, we could debate that. That's not quite the topic, but it is definitely something people are thinking through of like, how do we serve the patient and provide that education to prevent overutilization? But then I think that what it comes down to is, if I'm in a setting where my boss expects me to bill 4 units at every encounter, and this person maybe just needs 1 to 2 units every 1 to 2 weeks to touch base, then that puts me in a tough position. I think the article talked a lot about the patient clinician interaction, the society clinician or society patient interaction, healthcare system clinician interaction, but didn't talk about clinician supervisor relationships. And people have good ideas about, you can just advocate with insurance companies so that to help fight overutilization and blah blah blah. Well, yeah, that's all well and good if you have a ground to stand on, but when like my first job was for a chain that was 95 clinics, and my boss had been there almost 30 years, I have no ground to stand on within that organization regarding productivity reimbursement, other than I just got in trouble a lot. So I think that's a factor too as well that can make that decision making tricky.
I think it's important and to acknowledge the nuance to some of this stuff too. Just like on Chad Cook's podcast with Zach, he was like, obviously we have a problem right now with the fee for service, but also watch out if we change this, because a lot of the things that determine whether somebody gets better or not are probably out of our control. And so especially in the social determinants of health stuff. So now if we're acknowledging that people that are lower on the spectrum of the socioeconomic health are not going to get better, are we going to start, and if we're getting paid based on people getting better instead of fee for service, that becomes a problem now too, right? Because I don't know, it's complicated, right? And it's nuanced. And I think a lot that would change is helping acknowledge uncertainty and from the beginning. And I think people are coming in looking for an answer or looking for an answer online. And we need to acknowledge that a lot of the stuff while we know some stuff, we definitely know certain level of things. So there's still a lot for us to find out, and being able to kind of acknowledge that and hoping that other people in general kind of acknowledge how a lot of the stuff is a lot more complicated than just X and come in for X and then do Y and then you'll get, this, I don't know, result, I guess. Even the radiculopathy that you guys were talking about, Jared Hall and I got into a discussion for 3 days this week on radiculopathy, and we disagree. And Jared and I are both well-read people, and we disagree on the treatment of radiculopathy, and that's okay, right? But that we both acknowledge that there's a lot of uncertainty here, and we're coming in with different views on this. So being able to kind of acknowledge that, I think, not only from our side, but pushing that onto our patients and into society in general, that a lot of this stuff, even outside of healthcare, is very uncertain and not as clear cut as we want it to be.
All right. So I feel like we covered both domains 1 and 2 because we got into like the health literacy and patient side of things. Let's go to domain 3, clinician factors and experiences. There was, I feel like this will start a conversation for sure. The quote of, if physical therapists are movement specialists and corrective exercises do not work, what is the benefit of specialized one-to-one physical therapy over a general low-cost exercise program? So how would you all answer that?
Is all our intervention purely whatever the fuck corrective exercises are? I mean, you know, is any appropriately applied conditioning program or exercise program not corrective, right? Or is it not something else, right? The general exercise program that they're talking about, what is the general exercise program? Okay, I bend over and touch my toe 6 times, I do this. What exactly are we talking about? Are we talking they're back in the gym lifting and doing things? Are they just going for a walk? What level of intervention or what level of activity is it? And then if it's appropriately applied, is that not corrective, right? If it helps the situation, is that not defined by corrective, right? They had a problem, they did whatever it was, and now it's correcting. We can argue about whether or not that's true, right? But is that not? Where are we on what we're supposed to be, quote unquote, intervening with? Are we limited to the idea that we're just a corrective exercise profession, or are we just people that help people get better?
And to tag team off of that, are we limited by the idea that our intervention is only skilled if it's super individualized, right? That like, oh, I'm picking apart this person's posture and then prescribing corrective exercises is a totally different story than, say, the Lift More trial, which came up, which is general exercise, but within very specific parameters. 2 totally different things. One's skilled, one's not. But one, I think, would make a lot of PTs uncomfortable because it's not individualized one-on-one, me doing things to you.
I do want to point out that on the paragraph prior, they did mention paradigms for various musculoskeletal conditions are dominated by identifying abnormalities in posture and alignment, among others. And then they did a citation there. So they did mention that. So like they are talking about corrective exercises in the sense of like fixing some sort of posture and alignment or motor control or whatever you want to call it. They did.
Without a doubt, but I just don't think that, honestly, that's never been, and I've been practicing for 25 plus years, my definition of what I do, right? I don't look at this postural correction.
I agree. I understand where they're coming from, but I also understand where you're coming from. I do think that a lot of physical therapists do see themselves like this. So, and I think it's at least somewhat taught in schools.
100% taught in school. And that I wrote next to this, I was like, this is the $1 million question, because I can guarantee you 42 out of 44 people in my cohort could not even prescribe a general low cost exercise program. And so and zooming backwards in our musculoskeletal content, the biggest differentiator of threshold to treat is, can this person self-manage their condition? And if the answer to that is no, that's the threshold to treat for physical therapy. And if we look at it from that lens, which we've, in my program at least, been made to believe, then anything beyond, can they self-manage their condition, is enough to qualify them from the standpoint of there's value in spending one-on-one time with them. And what exactly does that mean? Well, that's a whole different conversation. But I was like, this is exactly, I mean, and that's really like, it starts in school, but it also kind of starts backwards of what are people's expectations of what physical therapy is, which is previous expectation, health literacy, and that bigger question of, well, where does that even come from? It comes from where they viewed healthcare in their entire lives, and whatever their first bouts of healthcare, and that goes into their social determinants, their experience, their access. And it's really the $1 million question.
No, go ahead.
I have a couple thoughts on this. So I agree with Alex. Like in our school, it's taught like for low back pain, you gotta subgroup them into the different classifications, stabilization, motor control and stuff, and do the corrective exercises for that, even though those don't improve outcomes any different when you subgroup them. But I like the thing, because they talked about the specialized benefit, one-on-one PT versus general low-cost stuff. But how many clinics really right now are truly doing one-on-one PT? A lot of it's 2-3 patients at a time with a tech who has often a bachelor's degree or in their undergrad right now with exercise science and minimal training with this. So can we really say that right now we're giving them specialized benefit of one-on-one PT?
And
But Nate, the
also,
PT checked
sorry.
off a paper checklist. That's individualized care. That's highly skilled. They starred the 1x15 or 2x10 that they wanted them to do. Come on,
Totally
man.
skilled. 3x10 all day.
I worked one place, no joke. Everything was 1x15. It was delightful. Yeah.
Shit.
No, I think
I
that's
wanna-
a really good question.
I want to touch on the academic piece, and I think I've dug myself into a deep hole of cognitive dissonance recently. So I'm currently writing a accreditation report for a developing PTA program, and no shit, I spent 2.5 hours of my day yesterday writing through bullshit CAPTI narratives about how I have to include some form of postural assessment in our program. That drives me up the fucking wall. Like, if the governing body responsible for what is happening in our education programs for clinicians, and it's not up to date with what we know, again, it's this never-ending cycle of like, where does this ownership lie in trying to better ourselves? Does it lie within schools? Does it lie within individual clinicians? Like, does it lie within the general population? Like, where? Or is it shared? And how do we get that across?
Just real quick, I feel like, this is obviously something we've spent a lot of time thinking about, because that's literally at the root of what we're trying to fucking solve. And ultimately, I do feel that the biggest responsibility lies within those within the musculoskeletal industry and the healthcare industry, because at the end of the day, people learn and understand these societal narratives and, folk models of healthcare by what they've ultimately heard, whether it's directly from or indirectly from some sort of healthcare professional, would be my overarching thoughts on that. So if we were to really, really try and hyper focus on, like, where can we potentially try and make improvements, it would be on everyone, every fucking one in the healthcare industry, students, professors, academics, researchers, clinicians, all of us taking ownership to do better and work collaboratively to try and limit that, because that's exactly the issue. I was that person that graduated from my school, and I was extremely seduced by the, pathoanatomical, pathokinesiological model of care. And I was that new grad going out, noceboing everyone and continuing to perpetuate these narratives without thinking twice. And I think that is a huge issue, is that academic institutions are graduating probably 80% of their classes, if not more, that are going out and continuing to spread these narratives. And I see that as a huge issue. And this is a tall fucking task, like you said, Geronimo. And I don't know how much control, but it needs to come from a bunch of different angles. But at least one place that feels controllable is starting to regulate and reform what's being taught in the academic institutions. And as it, spoiler alert for what it talks about later, but it, helping students grasp uncertainty better and be comfortable with that. That talks about in this paper, and it's recommended in all the different Lancet series on what we can do in terms of being more comfortable with uncertainty. And that starts with leadership from the academic position. Like, how are students going to learn to be uncomfortable with uncertainty if professors aren't having humility about the uncertainty of what's going on? So the ownership lies on all of us in the healthcare industry, in my biased opinion.
Honestly, Zach, that concept, obviously this is, and Jeremy, you said you have this cognitive dissonance. I'm living in that cognitive dissonance, and I think that's part of the problem to some students that are exposed to this echo chamber that we're in right now, in that you're spending the upwards of $150,000 to get this degree, that you also, if you know enough to step outside of what you're learning in school, you're starting to see this information that's negating everything you're learning, and you're like, how do I reconcile this lifelong debt that I'm incurring for this degree with the fact that this isn't, I'm getting other information that's telling me that I shouldn't be practicing the way that someone's telling me to practice, who is my highly qualified professor, whom I respect. And that's very confusing and perpetuates the exact problem you're talking
I have a question that might be uncomfortable. Where do you guys think that PT falls? Like, what would you guys like to see PT actually? Because we've been talking about like patients don't really understand what PT is, and let's just leave it at strictly outpatient ortho, right? Like not talking about inpatient or SNF or anything like that, just strictly outpatient ortho, non-post-op care. So your low back pains, your neck pains, like where do you guys want PT to fall there?
Are you looking for like the new tagline instead of movement specialist?
No, I'm
because
just
that's an inaccurate one for sure.
No, I'm just wondering, like, where do you guys think that PT should fall? Like, if we're saying that maybe general low-cost exercise programs are better, you know, like where does the doctor of physical therapy fall into this? Or should we be pushing people more to strength coaches or people that have these, you know, low-cost things going on? Like, I don't know. It's uncomfortable to think about, for me at least, because it's like, crap, am I adding to this problem?
So I can see it eventually becoming, or at least my current hope, this obviously can be very different and very wrong, but I view it, PTs as more of like the kind of what they're doing now unintentionally as like the managers of it. Kind of, I think of PM&R docs as like they're the ones who are kind of the managers of a lot of people's rehab. They'll come in, check in, have a couple tweaks, and then go back and have someone else implement it. So you could see something like that with DPTs being the manager of it, addressing a lot of things, and then having someone else perform a lot of the stuff with it. That makes it lower cost for them instead of having a $60, $80 copay every time they come in to see PT, which they're kind of unintentionally doing with having a lot of techs do it anyway right now. But at least those are my thoughts. They could be very wrong.
I think I would agree, but the problem it lies in that PM&R graduates 180 PM&Rs in the whole entire nation a year. You guys graduate that in two classes or whatever, 2 schools, and then we add in chiros, right? Because it's like the same shit. Like, that's a lot of jobs for a manager.
I think we're a little, oh, go ahead. Whoever was going to, I was going to say, I think we're a little bit hamstrung by the current model, right? And I think there are people who can do it well. Like, I had a conversation with somebody recently who did a rotation at Entropy Physio with Sandy Hilton and them. And he was saying how, sorry, I got distracted by the chat. It's like my brain can't multitask. PM&R is physical medicine and rehabilitation. So it's like a non-intervention, like non-surgical MSK. Would you say that's fair, Geronimo? They do injections and shit too. But you in that clinic, they're really fluid, right? Some patients only get seen for 1 unit of care. And for those of you who aren't in the US, our units are time-based. And then also the reimbursement is dictated by what code is being done within that time. So I think that really cripples us, right? In that to make ends meet, you often have to see either a shit ton of units within a day or have some sort of really low operating cost. And then there's this whole like, oh, I'm just going to go cash based. Well, then you're treating people who arguably probably need you the least, especially if we're thinking in terms of social determinants of health. So I think it's really hard to define what our role is when I can think of all sorts of ways that a DPT could be useful, but there isn't really that opportunity. It's not feasible within our current system. The one thing that I do think is helpful to think about in terms of that kind of idea of PTs as quarterback or PTs as a consultant is George Fox did a pilot several years ago where they got grant funding to have a PT in primary care full time. So it was a big primary care office with like 20 PCPs, and the PT could get called in. They just had walkie-talkies, and we get called in to do like a 5-10 minute consult on anything MSK. And I think they saw 1,000 patients in the first year. And what they found was imaging had been trending up before that, and it flatlined the year that the PTs were there. They did increase referrals to PT slightly, to regular, like, ongoing PT, but a lot of times it was just that check-in, that touch base of, oh, hey, you came into your doctor's office because your knee hurts or because your back hurts or whatever. We're going to call a PT in to take a quick look at you. You're fine. Come back in 6 weeks if you're not feeling better. In the meantime, stay active. Here are two, let's do some movement together real quick. All right, great. This stretch makes you feel good, so do that for some self-pain relief, right? And here's a little bit of counseling about physical activity. So I think something like that bridges that gap between being this manager overseeing things versus like a consultant that can come in alongside another clinician. But again, the model doesn't support that, right? Like, they needed grant funding to make that happen, or where they're doing it in Providence, Walla Walla, the PTs that do that do half a day in primary care. And then instead of seeing patients on the hour, which is what their outpatient clinic does, they see them on the 30-minute. So like, that's how they worked that there. So they're carrying what's expected as a full-time caseload in 20 hours a week. But I think most people on the East Coast would be like, 2 patients an hour? That's what? Like, that's easy. So that was a really long, rambly way of saying, I think there are lots of ways that we could be beneficial, but a lot of times you have to do other legwork to make it financially plausible.
I think this is kind of more related to Taylor's than Geronimo's basis of outpatient ortho, but it's kind of a passion of mine recently. But I think they've also seen that growing in emergency departments for PTs, acting as a similar role, just kind of also first line triage for MSK things and limiting overuse stuff. So it'd be more overuse in imaging and stuff than necessarily overuse of PT, like the topic of this. But I think that's a very interesting and growing situation for PT.
Something that I'm taking cardiopulm right now, and this came up. We had a presentation from someone. So I go to school in Boston, and presentation from a well-respected cardiac physical therapist at Beth Israel. And she was like, yeah, the biggest barrier to cardiac rehab is physician referral in cardiac rehab, which is highly concerning. And this brings up, kind of going back to your original question, Geronimo, I don't think it makes me, that question doesn't make me uncomfortable, because I think about the biggest issue that I see is that we don't synonymously understand each other's professions and the areas where we can collaborate better. And I think in like my own accountability, how can I do this? Well, I can create better relationships with referring physicians, with my community, because that's where it starts. It's like, okay, the national piece, that's really hard, but wherever I work or wherever I do clinical or wherever I go seek out care, I educate and seek to be educated in like, what is your perspective on physical therapy? Where do you see physical therapy within your practice? And then like, so I work at a gym and we create relationships with physicians in the area to be like, hey, when you have people that truly just need exercise, I can guarantee you we're qualified, and here's all the reasons. I can help you do your job better because I understand your priorities is to treat your patients. My priorities are to help people achieve whatever goals they have, and then triaging that. But it's like those relationships, I think, are the area where we can start that without trying to do this massive overhaul that I think we all want to come. But that really is something that takes a lot more than just changing, a conversation and hoping for the best.
Yeah, I mean, I agree definitely. I do think that the PT has value, and I think it's been shown as a like the first point of care. I do want to say that I don't know if it's so much of PTs being better at diagnosing musculoskeletal as much as it is they literally can't give out opioids. They can't, some places they can't image, they can't inject, they can't surgery. So like, because of that, but now we're seeing this problem with the overuse of PT, right? So like, obviously the opioid and the surgery is worse and more cost, and that's what we talk about. But is it so much that the PT, and obviously we're talking on average, right? We're talking in massive scale. Like we can't talk about an individual person, but on massive scale, is it so much that PTs are just better trained for MSK diagnosis, or is it that they just literally can't do this stuff, so they don't? Like, if you guys were allowed to prescribe, do you think that, and then you got point of care, do you think that you guys would prescribe just as much as MDs if you were allowed to? Because don't we kind of see that? I'm pretty sure I've seen this with the states that you guys have been allowed to start imaging. The imaging goes up because you're allowed to do it now.
Because I know the military PTs are allowed to order imaging. I feel like I'm gonna have to look up the site. I feel like I read that they have lower rates of imaging in military PTs than if seeing like a primary care doctor first. But obviously, it's higher than not being able to order imaging at all. I would assume it'd be similar for opioids, but I can't speak for that obviously because I don't know if any PTs can.
And I kind of want to point out that the authors on this paper, they're all under Chris Mayer, which is the leader of low back pain, is at like 450. They're all known as they're all PhD PTs. They're all known as anti-PT. Like, that's what people call them out for. And it's like, no, we're not. We're just, this is kind of what the evidence says. But a lot of people are like, you guys just don't want the profession to keep growing. It's just like, there is a problem here.
Part of the problem is the thought that the profession has to keep growing. Just point of fact, why do we need to graduate 1,000 other people when we don't know what care we're supposed to be providing and at what level, right? I mean, so we're creating this conundrum and feeding into the system because it builds up the educational model, which is where people have their own silo of interest in financials and everything else. So we have all these things kind of built in, and part of it is, well, we need to grow more so we can have more of this and more of that. But if we're not producing a product that's worthwhile, why are we creating more of shit, right? I mean, it doesn't make a whole lot of sense, but nobody's stopping. It's kind of like, can we, not should we? So as long as we can, we're going to, not should we type things. And that just bothers me.
Paul, do you see a feasible way of challenging that?
It's going to be half steps. I mean, kind of Geronimo's thing, right? Of, well, we need to be kind of over here. And the reason these guys are getting hit for the anti-PT is they're saying we need to be over here. But really, you're almost going to have to half step it because of all the nuance and all the things. What are the small steps? What are the small interventions to get us where we're going? And let's be honest, we're making judgments for something that may be 20 or 30 years, and shit may change. Our understandings may change along the way. So making that huge pendular swing may not always be the right swing, right? We may be swinging at the piñata and we're trying to hit the baseball. We're still swinging, but we're swinging at the wrong shit. That's going to change, right? So we need to be honest with ourselves and go, okay, let's half step it as things are going to change. What do we need to do? We can draw back on some of the educational models and not be so incentivized for some of that kind of stuff. How do we make healthcare costs less? Well, we also need to make healthcare school costs less so that people don't have $150,000 sitting on their shoulders to do stuff. How do we do all these things? Because you're not going to drive down healthcare costs when everybody that's providing it has 6 figures of debt sitting on their back. That shit ain't going to happen because there's too much financial incentive. There's people that start off altruistic and become Machiavellian because the shit is too much burden on them and I need to get out from underneath this. And how do I do that? That's also what drives people to leave the profession. Like, shit, I can't earn enough money doing this. I'm going to go somewhere else. And then they take on more debt to drive. You're not going to change that. So you're going to have to half step it with the realization that things may change as we go through this. And we need to make not big shifts, but small shifts. I know Zach and them want big shifts, but being honest, we're not sure that that's the direction we need to go. I think the thought process model and all that stuff, those shifts need to occur, but the actual effect and the actual changes of what we're trying to produce downstream, the methods change, has to be small because we really don't know things. Like right now, we don't know what we don't know, and we know things are going to change. I've been in practice long enough that things change constantly with you, and you have to stay engaged all the time and make minor shifts, not grand shifts, because you're going to choose wrong if you're choosing what's going to happen 30 years from now.
I'm definitely with Paul here, especially because this is not, so pain, musculoskeletal pain is not an America problem, right? And it's all over the world, and all over the world that we look at these healthcare systems that we want to aim towards a more maybe socialized healthcare system or whatever, or some people want to and get away from fee for service or whatever. But Denmark and Canada still have a very big, massive chronic pain problem. You know, you go to England and you can get your PT degree for nothing, but they still have this exact same problem. So is student loans really the problem? Like, you know, like just like how you're saying, like we think that we have a solution, yet we're seeing these other countries that have done this, right? You can go to England and Europe and do your grad school for virtually nothing compared to the United States, yet they still have this problem. You know, they have a different insurance, yet they still have this chronic pain problem.
Right, and they have a different societal model, and they still have these issues, right? So we don't know, so why are we going to make huge steps when we really, really don't know?
And to your point, Paul, too, I think as we make smaller steps, that doesn't preclude the opportunity to do a bigger shift, right? Like in chunks or in, you know, isolated areas. Like, all right, somebody doing the Lift More trial. What if we got something like that in the US? George Fox piloting PT and primary care over the past couple of years, right? And now it's starting to scale and go to other healthcare systems in the region because we actually have data.
My group was in a neurosurgeon's office doing screens to say whether or not that patient could benefit from therapy, right? Because the surgeon didn't know. I don't know what you guys do. And I want you in here to tell me whether or not this guy you think, and this is a triage, you got 5 minutes in the room, do you think that they're going to benefit from therapy or not, right? So that was 22 years ago, and we're still half-stepping along and making things, but we should be involved in these discussions, like Alex saying, reaching out and having that conversation, because I've worked closely with many physicians, and some of these primary cares, you go back in and go, yeah, you know, when you do this to a knee, okay, that ACL is gone. We need to do something other, right? I mean, it's different, right? And there are things that we're good at, and we need to be able to do that, but we need to also be humble enough and have that discussion, because they need to be humble as well. And it only starts if we come in with humility, right? Not like a subservient dog, but with enough honesty and saying, hey, look, I'm good here, you're good there, this is my understanding, but where do you come from your understanding of my stuff? Here's where I see things. And having those dialogues and really bridging that gap between providers is the only way that it starts to change a little bit, because now I can say, okay, maybe we don't need X, Y, Z. But telling, again, they're under the same pressures. Telling a physician that's got $163,000 worth of debt, don't run this and don't do this, because you're not going to change that unless you're having open and honest discussions. And those are going to be back channel. Those aren't going to be in the clinic where everybody's defensive and thinking this other stuff. It's going to be having the beer afterwards and going, hey, so what's this, right? And we've got to get to that level where we're having those conversations across all boards, bringing the strength coach in, bringing the ATs in, bringing this in, bringing the chiros in, everybody having a sit down and just doing that. But that's going to happen back channel, or like this, right, where we have a broader scope of people across the nation. That's what's going to do. But these dialogues, and that's what I think, I love the Level Up Initiative. I love that grouping of let's all sit around and talk and learn, right? Because that is part of it. I've been in this a long time, and I still love getting out and doing this, because this energizes me, seeing that people want the changes that you see that need to happen, and people discussing, you know, Geronimo was asking the big questions. So how do we change this shit, right? Well, okay, we don't know, right? But being open and honest and saying we don't know what we need to do, but we can identify certain areas, and we need to be working on those areas, right? And it goes back to the old trite little bumper sticker of act local, think global, right? Do what you can do in your little local way and in your thing, and have that broader scope thought process behind it.
Yeah, I mean, I'm thinking about this in terms of, I wonder, and I would love to hear what all of your perspective on this is, the variability in the people that graduate from PT school. So we talk about patients having this perspective on the healthcare system based on their previous experience. I think it's the same thing with these relationships with physicians. And if we're trying to make this global change where certain professions or certain national bodies don't necessarily respect musculoskeletal outpatient orthopedic physical therapy due to previous experience, because there is, I mean, you talk to if all of us were to create a treatment plan for a patient, there would be vastly different treatment plans, and it's very hard to reconcile some of those items. Where in the medical profession, you treat two patients with the same condition, the likelihood that they're really similar is pretty high. And so how do we combat some of that? Because I think that poses additional challenges for us. And I think, you know, maybe within us 27, it would be a little bit more similar, but then you step outside of that and you look at, you know, all the PTs that graduate nationally and then work in outpatient orthopedics, you got a whole host of different things going on. So do you think that that plays a role in this challenge that we're met with?
Yeah, 100%. I mean, and that's why I kind of try to always talk about, like, we're talking about the average here, like what are we seeing in these trials? Because obviously we come down to the average, not the individual. And so like that's why I find it hard to reconcile some of the thoughts that I have, because it's my thoughts are like, maybe the best thing that we should do is try to make the clinician be as far, like try to take the clinician out of the equation as much as possible. But I only say that because the average, according to the data, is just it's not good, right? Like how many actually follow guidelines. But then I see great clinicians and I'm like, I would love for you to see everybody in the world because I know you're really good at this. But it doesn't,
you're making this like, it's like an individual person. You're saying, oh, I trust this clinician. Like I have this problem. I have few people that I would send some of my clients that I work with. And that's a sad fact. Like I want to vet the PT that they're going to go to. Me as a PT student am vetting a physical therapist because I don't trust them to take care of the person I'm trying to send them to. Like that is absolutely part of the problem. But I think that's also part of the solution, is being able to say, and it goes back to Paul, what you were talking about earlier of like, what am I good at? What is my role within this? And I think Nate, you also talked about this too, is like, okay, if I'm honest with myself about what are my skills, where can I insert myself best for this patient? And maybe be like, we need as a profession, maybe to be more proactive about communicating those elements and like identifying what is our role based on what are our particular skills. And that does definitely vary person.
Here's my thing, and I think this is where they have to start. But I don't think that we can push for some of these things until we get the PTs where they're at least at a reasonable guideline adherence. Because this is the exact same author group that did the RPTs are following guidelines or whatever. And it was like 30% are, and the guidelines are bare minimum, like education, exercise, and they added manual therapy as an adjunct is allowed in the guidelines, right? And yet only 30% of PTs were meeting these guidelines, and it was a large sample size. And so like it's really hard for me to promote or push, yes, we need to get PTs ahead on this stuff, or DCs, whatever, but it doesn't matter, PTs ahead, when the majority, according to the data that we have, aren't meeting these bare minimum guideline adherence. And like, just like you said, we have our own problems with us that know this type of stuff, trying to find somebody in our own area. So that says a lot about our professions, right? Like, and the data shows that exact same thing. So until we get somewhere, until we raise the floor, I find it really hard for us to try to push for more. Which sucks because there's really good clinicians. Like everybody here, you're spending your Saturday morning talking about this stuff, having these conversations. And it's really hard for me to look at you guys and say that. And then also, you know, like, I don't know, it's troubling for me at least.
Yeah, I think that is a point, because you're talking about the whole like problem with the Get PT First movement. And a lot of the stuff that we use to advocate for Get PT First is based off of studies and trials and stuff about good interventions, like interventions that follow the practice guidelines and stuff. But yeah, if a third of the clinicians out in the world are following it, can we really say Get PT First if we know 2/3 of the time they're not going to be getting what is actually we're advocating for?
Well, I'll argue this counterpoint. just from it depends upon what we're looking at. Because if we're looking at the choices, go get an MRI and get your opioids and get an injection. Okay, get PT first, because at least all I'm going to be doing is making you dance on your head and juggle while standing on a BOSU ball. But that's going to be less costly and less dangerous to you than those other interventions. Now, if we're doing get PT first because it's better than another musculoskeletal intervention or another group of exercises or another thing, then maybe not so much, right? Because now maybe we have some people, the juggling act isn't going to be as good, right? So what are we comparing it to? I'd argue that it's a good half step away from more deleterious things, but it's not, once we're there, it's not necessarily better than any of those other kind of things along that same sphere.
That's only if assuming that that person isn't going to then go from our care, and because our care was not guideline adherent, and we're going to assume that that person does or does not get better, but that second time they now might be more looking for more medicine at that point, right?
Yeah, if they fail, they're going to go to that next level, right? Right, quote unquote failed. Yeah, I see. I mean, I get you that we put another cost barrier in front of going and getting those other things as part of that. But do we have enough data points to say whether or not that is? Because most of the literature I've seen when we're doing the PT, push PT first, is against the opioids, and it's against some of these other kind of things. I mean, that was a primary drive. So against that, we might be a little bit better off, might be, right? But I don't know if we have enough data points to show that what's the recidivism rate above and beyond what we already know that it is, of falling back into and going back into the medical model as far as the opioids and injections and some of that other kind of stuff. So.
Right. Yeah. I think we just don't have the longitudinal data, right? So like in the short term for sure, but we don't have that data on if you don't follow guideline adherence care 5 years from now, are you now more likely to get opioids because you've seen a PT and you failed, right? So you don't even give that PT a chance anymore because you failed.
Right.
Well, and just because you didn't get guideline adherence care once, how many times do we see a patient and they're like, oh yeah, you're the fourth PT I've seen for this condition? Well, of the 3 people before me, most of the time it wasn't guideline adherent, or maybe there was some good stuff, but they missed the mark, whatever. So then that would make it really tough, especially in the US system, to track, right? Because we don't have that centralized data. So if you're doing their study within, multiple hospital systems, and this person, 2 of the 4 times they got PT went to private practice, how do you even reconcile that?
Can you guys hear me? Okay. Sorry, I was distracted. Alex left, but to answer a question earlier, I think one of the things we can do to kind of, work our way towards this issue is start integrating like interprofessional classes with like multi-disciplines. So like I know like, for example, some PT programs are in hospital settings and they do some classes with like other med students and etc. I think even starting from like semester 1 would be good for something like that. And not even just like in that medical system, but with other professionals like, or even other professions like chiropractors, athletic trainers, exercise physiologists, things like that. That way we have a clear understanding of what everyone does from a more like when everyone's a student, because that student phase is when everyone's just kind of like still absorbing information. And so it's kind of like when our biases are either confirmed or I guess not shut down, but like challenged. So, and everyone comes into their respective profession with their own biases. I mean, my bias going into PT school was like exercise was key, and then all manual therapy was like whack. My perspective has changed over the years. I'm still really biased towards exercise because I mean that's my personal bias, but I mean I've learned to kind of look at other perspectives because of that. But and I think that's also why a lot of people graduate PT school with imposter syndrome, is because there is no like PT school they don't teach you like a clear-cut method, they teach you like everything, bad and good basically. So it's and it's mainly to pass the boards. So I'm not sure where I'm going with that. Just my opinions on that matter there. So,
Joey, to the interprofessional side of things, when I was a first year, we had a class like professional issues, which was PA, OT, PT, speech pathology, and one other, and no one took it seriously. And that's my worry, is like when you're a student, that you're going to pass that class because it's the easiest one, and no one's going to take it seriously, and you're almost going to like be more dissonant with the professions when you leave, because it's like you stand like you want to say why you're in school for this, and you're almost like trying to argue why you're a PT or why you're an OT, and it's like it's not even interprofessional. But I mean, that's just my experience in my program. Megan, do you have thoughts?
No, we had the same thing. So we had a class just like that the whole first year, and very similar. No one took it seriously. It was pass fail, easy class. We had problems because we had class on Saturdays sometimes. So already it kind of set people up to be like, I hate this. And so a little bit of a backfire effect, I think, sometimes.
Yeah, which I think you guys are hitting on something that I think has been kind of tangentially relevant to a lot of these discussions today, which is kind of this ownership of professional growth. And I think one of the biggest obstacles, and this is just my opinion, obviously, but I think one of the biggest obstacles, even to making the half steps that Paul was talking about, is that people want to punch the clock and go home, whether that's in school or whether that's, after school. And I would also add that often there is more incentive, at least financially or even academically, to do that, right? Like Geronimo and I have talked before how we've each come under fire from our programs for decisions we've made about like not going to class, because I'm not going to sit through a bullshit guest lecture when I'm paying $36,000 a year and I could be shadowing Scott Morrison. Like, why is that's not even a decision, right? Like, of course I'm going to go hang out with Scott in clinic and not sit through some stupid yoga lady trying to tell me about alignment. Like, come on. But the system is not set up to necessarily incentivize people. Like, you have to be pretty damn bold to make that sort of decision and pretty damn invested. And I see that even, like, I was talking to a classmate the other day who initially, like, we were both planning, like, all right, we're going to try and get our sports cert in the first 2 years independently. Like, let's cheer each other on. And he was like, man, he's like, I just had like my wife just had her first kid, and I don't know how I'm going to be able to stay up with current evidence because I'm so tired all the time. And when I come home, I just want to be with my kid, and, on and on it goes. And like, I'm in a different life stage, obviously, but I think surrounding all these conversations that we're having is we also need to be real about how do we like help our friends or build relationships with people who aren't as motivated as us. I think Level Up is a great entry point to that, but then also to remember, like, reach out to those classmates who might be less motivated if you have that kind of relationship with them. And I think that can be a really practical way to start pushing them, pushing yourself, or holding yourself back, as the case may be, in a good way, so you're not overbearing on them. But I think, there are people who have kids and can figure out a way to get it done. So like, all right, y'all are rock stars, start calling out or calling up, other people in your shoes. And, for me, I'm doing that for people in my life stage too.
I think I challenge you guys as well to, it's good that you're sitting here and talking about it, but like also make an action out of it, right? So like right now PT is going through towards psych-informed care, right? Like that's the big thing right now is like psychology informed PT or whatever. And something I see I've talked about a lot is a reminder that you are not psychologists. So even though it's important to be psych informed and know where that line sits, where you might need to then actually need to refer out to a psychologist. And then we talk about that and everybody kind of shakes their head. And I'm like, okay, so if you're practicing right now, do you have a psychologist that you refer to? Have you talked to somebody? And most people say no. And then, so this was the kind of the situation that happened between Jared and I this week was we got to a point where like, yeah, we agree this is how you treat somebody. And he's like, yeah, but I don't know any surgeon in where I live that isn't like surgery right away. Like if I refer to a surgeon, it's like a surgery right away. And I'm like, come on, man, you live in Dallas. There's no way that you think that there is not a surgeon out in Dallas that is not decent. So like, obviously you have not, done this, right? Like you have not tried to reach out to these other professions and learn from them. But to that point, I think Jared is great. And so like, are we all sitting here talking about it, but then now we're going to go home and not do anything of the action? Like we all know the steps, but we don't make the actions to reach out to people. Like, have you reached out to psychologists near you? Have reached out to MDs near you and had these conversations? Or are we just talking about them? Because I think that's the important part about this paper too, is like, yeah, they point out all the problems, but they also try to give you solutions, because that's important too. Anybody can talk about problems.
All right, do you all want to briefly touch on the table that was mentioned? I think it has really good examples of overuse and then kind of the drivers and potential kind of approaches to improvement. And then maybe we wrap it up after that. There was three different examples. Did any of those four different examples, did any of those like pop out to y'all or have any things y'all wanted to cover? The first one was diagnostic imaging for low back pain. Second was referring patients to a medical doctor for opioids for MSK pain. 3 was referring patients for arthroscopy for knee pain. And 4 was over-reliance on manual. Are there any of those 4 that y'all want to hit on initially?
I mean, I know as a chiropractic student, the idea is diagnostic imaging, is our savior. And in every adjusting class that I have, it's if you don't image somebody, then you're missing out and you can't fix the problem. And, it's hard and there's a gap there, because even when you try and have conversations about literature and clinical practice guidelines, the educators perpetuate this narrative of, well, unless you have experience, the research isn't important. Or if you read the research, my experience is more important. So, in that aspect, for me, it gets challenging to try and have conversations with students, because as we talked about earlier, one, a lot of them aren't necessarily motivated to read in the first place. And 2, now I have a professor who's saying, well, the research really isn't that important because you don't have any experience anyway. And since I have experience, you need to listen to what I have to say. And it creates a really big gap, at least in that setting, for me and other classmates who are chiropractic students, because now we have this idea that this treatment that we're supposed to provide, that is supposed to drive, I guess, our income as far as a chiropractor, is strictly based off of the imaging that I take to help drive that treatment. So, it's really hard to even have that conversation, because in the minds of a lot of chiropractic students, it's, well, the only way I get paid is if I adjust somebody. And the only way I can adjust somebody is if I take this image. So, for me, it's challenging. And I don't have great answers, because obviously I'm still learning, and try not to challenge too many of the professors, especially since, I do want to respect that they do have more experience than I do. But again, there is a huge issue, at least in chiropractic, that, imaging drives what we do, regardless of what any of the research says or literature says. And even when we've had in-class discussions with students about how they feel about imaging and how it perpetuates treatment, I would say 80% of them had some sort of idea that, oh yeah, why wouldn't I take an x-ray? Because what if there's something there? So again, we're moving more away from the idea of taking a good history, getting to know who the person is in front of us, really trying to understand who this person is, and focusing more on the subjective instead of driving to, well, I need to image and treat this person so I can get to the next patient and continue to make a quick buck. that may have been really aggressive.
So that was a little aggressive. So that goes back down to the problem of not knowing the literature, right? Because I think that the problem here lies, and a lot of people have this, and it's the same problem with screening, right? Like we think that more information is better. And the problem that I've always asked, because I'm in Cairo school, and so we get the same thing, and I'm sure you guys at PT school get the same thing of like maybe you image just in case you miss something. Then I asked them, I was like, what's the sensitivity of X-rays for this condition? And it's really low. So like if that is your reasoning for imaging, you have to MRI, because you can't rule out the sensitivity is too low. You can't rule out cancer or any of these things that you are maybe going to catch, right? So now we should MRI everybody, and then everybody's like, oh no, we shouldn't MRI everybody. That's too much. I'm like, then your whole entire thing falls apart, and that's what I found has been useful to being open to that conversation. I obviously say it in a little less direct tone to my professors, but whatever.
Yeah, and I think too, like if people don't recognize their own bias, you're not going to get anywhere in changing their mind. I learned that the hard way when we had, I don't know if she was a PT or an OT, but she was a hand therapist that came in and was going on and on about K-tape for swelling and how it's so helpful and this, that, and the other. And I finally just asked her, I was like, how do you know that you're not committing a post hoc fallacy? Like, how do you know that their swelling wouldn't have gotten better anyway in the same time period? And she like didn't know what a post hoc fallacy was. So that was like super awkward. She was like, what was that thing you mentioned? And I asked her them for the entire class. Maybe not the best idea, but for getting that buy-in. But yeah, like if people aren't willing to acknowledge their bias, like, and that like we all are subject to it, right? Like that's partly why we're here having these conversations, because we know we're going to get shit wrong. We know that we're going to want to see things through a certain lens, but also knowing that it's not always bad to have our biases confirmed. It's just good to be aware of them and challenge them, right, alongside having them confirmed. But if people are up on their high horse and think they're infallible, good luck, man.
Yeah, I think it comes back to kind of Geronimo was leading to this, where, okay, if we have this more information, what does it change about our treatment? If we get information, okay, we have like one potential yellow flag, and we investigate that further stuff, is it going to, if we find one small thing on an imaging or anything we do, how much is that going to change our difference? If we come back and the patient has lumbar spinal stenosis, is that going to really alter dramatically what we do? And if not, then we're just incurring more healthcare costs and expending more time and energy for the patient without really driving a change in our treatment.
I found that with my classmates, it's not so much, and I know we talked about this earlier, of like lack of motivation. I think that everybody comes into these schools, like nobody does PT, DC, or I hope nobody does, as anything except for being motivated to help people, right? I do think that the motivation is there. I just think that some of them haven't seen some of this data that we're kind of discussing here. And that's why when people ask me like, what is the first paper I should read? I usually send them like the Ben Darlow stuff, because that really lights a fire up on your ass. Like after that, we can talk about whatever you want, but until you realize like how much, like these problems that we're discussing here, and I think that is more of a problem in my cohort, is that my fellow students they don't know some of this stuff, or they haven't seen some of this data on like what is going on, like why is musculoskeletal care costing so much. Like we spend more of it in America than we do on our military, and we're known for spending a lot of money in our military, right? So like why are all these problems happening, and why are we still so bad at it? And I think the motivation is there, just not the acknowledgement. And it's the school's fault for not mentioning this. Like it's ridiculous that I go to Cairo school because we're spine specialists and nobody's mentioned the Lancet series on the back, but it's another take for another day.
I think I don't know. I think I'd push back on that. Like showing them the Darlow paper, maybe will light a fire under their ass for like 2 weeks. But I was talking to a buddy in my class of like, he brought up a good point. Like there's just a bell curve with any profession, and with healthcare and in grad school in general, like the vast majority of students get into grad school because they're good at taking tests. And in grad school, you're taking tests all the time, and it's a fire hose of information. And to think people are going to prioritize outside information that goes against what they're learning in school that they have to take the test for, showing them one paper or a handful of papers, like there's the bell curve of like, it will impact probably one or two people. And then the middle ground kind of care, but like don't really. And then the other, like the lower like side of the curve is just, why are they even in grad school? But I don't know. I just think there's way too many PT programs and probably chiro programs of like the volume of people coming into these programs. Like you just have to get good enough grades and not be a sociopath, and you'll get into like PT or chiro school. And that doesn't really filter out like the people who are motivated enough to actually like pursue further education for the rest of their life.
Yeah, I completely agree with that, Chris. And I think a lot of people hide behind that I just want to help people, which I think is honestly bullshit, because like you're either lying to yourself that you're helping people enough to make it worthwhile as a career. Like there's so many different ways you could help people, right? Like you could be a nurse and help people, and your debt to income ratio would be a lot better. Yeah, exactly. Caffeinate people is helping them. That's a bullshit motivation, because I don't think it lasts, right? Like you have to, yeah, like it's good in the moment, but what do you do then when you have those days or weeks where your patients aren't getting better? What do you do then? Like I had one classmate tell me, oh yeah, I'm glad I got into PT school, but it's, if I hadn't, I would have just done an accelerated nursing program. I was like, then why the fuck are you here? Like, why? And there's so many clinicians that I'm just like, why are you even here? Like, I don't understand, because I feel like, I don't know, I'm going to stop ranting before I just get off topic, but I'll leave it at that.
There's a lot of PT students, and probably chiro, they're in PT school because they couldn't get into med school. And what does that tell you about like the people in our cohorts? Like they didn't get enough good grades, or want to have the motivation to pursue that long of an education. And now this is like their backup plan. And a backup plan for your career, I don't think that's an ideal thing.
Yeah, and let's not forget, like, also, this is like a little bit of a tangent, but I don't know if any of you guys know Mike Macker. I don't know how you say his name. He's like one of those obnoxious people on social media that lurks but never posts pictures of himself. So you're like, who the fuck is this guy? Anyway, I'm in a journal club with him. He's a really well-connected dude. But he was saying, like, it frustrates him so much that so many of the, like, even moderately roasted popular, like, PT accounts are not necessarily from people who are particularly good PTs. And I see this a lot of, like, especially amongst women, that, oh, I'm going to post my pictures of me in my fig scrubs and me from my white coat ceremony, which, like, fuck that. Like, I don't know. Like, stop hiding behind this, oh, I'm an expert, I'm training to become an expert. And it's, like, almost become this branded thing of, like, I'm a med student light. Like, why? Just stop. Like, that's not helping anybody. You think you're helping people. Like, stop spending so much time curating this image and instead curate yourself as a clinician, right? Like, I don't know. That's my rant of the day. I'll go long periods of time without posting anything to my feed because I'm working on myself, y'all. Like, come on.
I have that same problem with when we talk about the opioid epidemic, and like, or over surgery is, it's kind of like that glass house. I'm throwing stones from my glass house thing. That's why I always like to mention it. And I get a lot of shit for saying this at school, especially at chiro school, because, anti-medicine. But when I say that DCs and PTs are just as much as fault as MDs for the opioid epidemic. And then, everybody looks at me and I'm just like, I mean, come on, if we were better, we wouldn't have gotten there too, right? Like, even if we also mentioned that, like, our organizations haven't been putting out this information prior to when the opioid epidemic started as well. And they might not still, like, it's easy to be like, oh my God, look at them. They are killing a bunch of people, right? But what were we putting out information-wise in the early 2000s? You know, were we ahead of this? Were we warning people? And I just haven't seen that. At least I've gone to look, and I haven't seen that we were kind of saying this is a bad idea. I don't know if you guys have seen any different.
Yeah, no, I agree with you, Geronimo. I think that's still an issue. I mean, I had a client call me last night. She's in Texas, a CrossFit coach, had a probable disc herniation squatting yesterday, went to the ED because something popped and, excruciating pain, whatever. They put her on opioids and didn't tell her that it was an opioid. She's like, what is this prescription that they gave me? She's like, it makes me feel funny. And I'm like, don't fill your script. Stop taking that. And some people would say that's not my scope of practice to tell her that, but I'm also like,
for sure,
this is like somebody was acting outside of best guidelines. They also told her to rest until it stopped hurting, which is also not guidelines-based care. So fuck them. I'm going to step outside of my lane and say, don't fill your prescription for opioids. Did I have good ground to stand on?
You need to delete that part of the recording, Chris. For sure illegal.
Oh shit, I forgot it was recorded. I'm ranting over here, dang it. I'm ranting while I'm curling my hair, just so you guys can picture this. I've got my Zoom graduation today, 7 months after the fact.
I think part of it is just a balance of relationships with the doctors. And, I'm in my second clinical right now in an acute care hospital. And a lot of it is dealing with, well, the docs think that opioids would best manage this situation. And you don't want to step on toes saying, well, here are some other thoughts that I have, because then they don't want to work with the PTs quite as much, but then you're not really doing your part in counteracting this crisis. So I don't know. That's kind of the struggle that I've seen with this situation, kind of in this clinical and then in the clinical that I had previously in an outpatient orthopedic setting in a hospital where we worked closely with the surgeons and had a lot of low back pain patients. And it was just, well, they think that opioids would be a good solution right now. So that's what a lot of the PTs would recommend. And it was incredibly frustrating, but they didn't want to get at it with the surgeons, and surgeons know more. And so I don't know.
I think it's important to talk about, like, there's a very much a nuance to the opioid conversation as well, right? Like, I know that we have now gone the exact opposite way, and the terrible thing about this is that prescriptions have gone dramatically down, obviously, but deaths are still rising. So the conversation is a lot more nuanced. And I have never had that conversation. I don't know enough to have that conversation. I just follow people that are much smarter than I that do have the conversation. But I think that's important too, is like, even in this and like the opioid conversation, there is some nuance and some uncertainty, and there might be a place for them. And I don't think it is in chronic musculoskeletal pain, obviously, but there are like maybe post-op care and tailoring people off of it, right? Like, that's also a huge situation now that people are we created people that have an opioid addiction situation going on, and then we completely took it from them. And that's a whole issue in itself, right? And pain is still a problem. So that's why I think it's a lot more uncertain and nuanced, and maybe even something that we think is so opioid bad can be.
And Geronimo, tying that to social determinants of health, I haven't done a deep dive into the literature on this, but the issue that I saw a lot in acute care was patients who have a history of, non-prescription drug abuse really struggle with pain management then, because their tolerance is so high. And those are also the people that don't have great social support, don't have great housing or food security, on and on down the list we can go. And then you've got all these confounding factors as well. And they're still on opioids,
To piggyback off that, I think a lot of the stuff that we're talking about here is really important, but I think what I try to recommend people is to get involved, and not just in their organization's local, like APTA or anything like that, but also like who the politicians around you and what they're kind of being pushed, and don't just become part of the conversation when like PT reimbursement is potentially being cut, but also be part of the conversation when they're talking about, you know, building more green spaces around you, or, you know, starting another place for people to be able to sleep at night and stuff like that, because that is going to benefit pain a lot more than, you know, the next manual therapy or the next exercise that comes into, you know, popularity. So I think that that's important, is like, remember that if you are trying to help all these people with pain, maybe being part of the conversation that you think is maybe outside of the PT profession, but it's still your civil duty to at least, you know, push that stuff when it does come up on a bill in whatever your local area is.
And then you have the connections to refer people to services, right? So like if you're treating someone, like I had a patient who on his PFFS, his number one goal was find a place to live. Well, like, oh shit, that has nothing to do with his neck pain, but it has everything to do with his neck pain at the same time. You know what I mean? And like, I had to do some digging to even know who to refer him to for that. So yeah, get involved beyond just your profession.
I think that's a perfect stopping point. Does anyone have any other closing thoughts or questions? Dope. Well, thanks for joining this party. Thanks, Geronimo and Taylor, for leading it. I tried to talk as little as possible. So this is great. If you want to join more of these parties, I do them once a week on Saturdays. We're going to do elbow for the next 2 weeks, and then we're going to have Christmas, and then we're going to go from there. But yeah, thanks again. Y'all enjoy the rest of your Saturday. And all right, ending the call.